Hello and namaste everyone. Today we are going to talk about the middle cranial fossa of the cranium. The middle cranial fossa is situated posterior to the anterior cranial fossa at a slightly lower level. This fossa is sort of butterfly shaped, having a narrow central part formed mainly by the body of sphenoid and wider lateral part formed mainly by the greater wing of sphenoid and cerebral surface of squamous temporal bone. The floor of middle cranial fossa is at the level of upper border of zygomatic arch. The fossa contains pituitary gland at the center and temporal lobe of cerebrum laterally. Middle cranial fossa is bounded anteriorly by the posterior margin of the lesser wing of sphenoid on lateral aspect and by anterior margin of sulcus chiasmaticus on the central aspect, whereas its posterior boundary is formed by the anterior sloping surface of the petrous part of temporal bone. The sella turcica, which basically means like a Turkish saddle in Latin, is a central hollowed out depression in the upper surface of the body of sphenoid. From anterior to posterior, it consists of three parts, that are the tuberculum sellae, hypophyseal fossa, and not clearly seen dorsum sellae. The anterior bulge of the body of sphenoid is the tuberculum sellae, which has small elevations on either side, which are known as middle clinoid process. The hypophysis or pituitary gland is situated in hypophyseal fossa of the sella turcica. The upper border of dorsum sellae ends at posterior clinoid process. A dural fold called diaphragma sellae runs from the tuberculum sellae to dorsum sellae, forming the roof over the hypophyseal fossa. This fold, the diaphragma sellae, has a central perforation which allows the passage of pituitary stalk or infundibulum. Diaphragma sellae is an important surgical landmark during surgeries such as transsphenoidal approach to reach pituitary gland. Sometimes diaphragma sellae is breached, leading to shrinking of pituitary gland due to cerebrospinal fluid pressure, which is known as empty sella syndrome. The diaphragma sellae continues laterally over the roof of the cavernous sinus that is present on either side of the body of sphenoid. The roof of cavernous sinus is pierced anteriorly by internal carotid artery between the middle and anterior clinoid processes. A groove situated behind jugum sphenoidal or situated in front of the tuberculum sellae is known as sulcus chiasmaticus. It leads bilaterally into the optic canal. In spite of the name of the groove, the optic chiasma is present postero-superior to sulcus chiasmaticus. The optic canal, which transmits the optic nerve, that is the cranial nerve, to ophthalmic artery along with their meningeal coverings, is enclosed by lesser wing of the sphenoid and the body of sphenoid. A cleft bounded by the body of the sphenoid, the greater wing and the lesser wing of sphenoid is known as superior orbital fissure. Like optic canal, which we mentioned previously, this fissure also connects the middle cranial fossa to the orbital cavity. The fissure serves as an important passageway for many cranial nerves and blood vessels, which are vital for the movement of the eye, sensation of the eye, and blood flow to the eye. The superior orbital fissure transmits the superior and inferior divisions of the oculomotor nerve, the three branches of ophthalmic division of trigeminal nerve, trochlear and abducent nerve. This fissure also transmits the superior ophthalmic vein, anastomotic branches of middle meningeal and lacrimal arteries, inferior ophthalmic veins, and sympathetic nerve fibers. The compression of the structures traversing through the superior orbital fissure can cause superior orbital fissure syndrome, which is also known as Rochen-Duvignier syndrome. And this syndrome features as diplopia, ophthalmoplasia, that is the paralysis of extraocular muscles of eye, ptosis, pupillary changes, and sensory loss of forehead, eyelid, and cornea. The greater wing of sphenoid, which is also known as alley sphenoid, presents a number of important foramina like foramen rotundum, foramen ovale, and foramen spinosum. The foramen rotundum, which in Latin means round opening, lies at the anterior and medial part of the greater wing and connects middle cranial fossa to pterygopalatine fossa. It is responsible for transmitting maxillary division of trigeminal nerve. The prominent foramen ovale, which in Latin means the oval opening, is present posterolateral to the foramen rotundum. The structures passing through foramen ovale are mandibular division of trigeminal nerve, accessory meningeal artery, lesser petrosal nerve, and an emissary vein. If medicines are unable to treat trigeminal neuralgia or tic doulourix or Fothergill's disease, percutaneous rhizotomy using either radiofrequency ablation, balloon compression, or glycerol injection can be carried out. The term rhizotomy is derived from Greek term rhiza, which means nerve root, and tomy means to cut. The foramen ovale can also be used as an entry point when carrying out this rhizotomy. The foramen spinosum is a small opening situated posterolateral aspect to the foramen ovale. Foramen spinosum connects middle cranial fossa and infratemporal fossa. It transmits middle meningeal vessels and nervus spinosus, which is the meningeal branch of mandibular division of trigeminal nerve, responsible for supplying the dura mater of middle cranial fossa. The knowledge of anatomical variation of foramen spinosum is important because vasodilation of middle meningeal artery has been linked with migraine headache. Additionally, due to its distinctive position, this foramen acts as an important landmark for neurosurgeons and radiologists during middle cranial fossa surgery and radio imaging. Sometimes, a couple of inconstant foramina may be present in the greater wing of sphenoid, such as foramen of Vesalius or sphenoidal emissary foramen, situated between foramen rotundum and foramen ovale. The foramen of Vesalius can be seen over here, and not seen over here is the foramen innominatum or foramen petrosum. These foramina have been dealt with during the talk on middle part of inferior view of the skull. An important irregular gap known as foramen lacerum is bounded by the apex of the petrostemporal bone, body of the sphenoid, and adjacent greater wing of sphenoid. The foramen lacerum is formed by the incomplete fusion of the sphenoid and temporal bones. In living body, foramen lacerum is closed by a fibrocartilage at its inferior end, which can be observed during inferior view of the skull of living person. As mentioned previously, carotid canal, also observed during the inferior view of the skull, opens into the posterior aspect of the foramen lacerum. Thus, we can observe the internal carotid artery arching over the foramen lacerum and moving anteriorly towards the cavernous sinus. From the anterior wall of foramen lacerum, pterygoid canal begins, which ultimately ends at pterygopalatine fossa. The foramen lacerum is also a site of union of greater petrosal nerve that carries parasympathetic fiber from facial nerve and deep petrosal nerve that carry sympathetic fibers, thus leading to the formation of nerve of pterygoid canal, also sometimes known as Vidian nerve, which reaches the pterygopalatine ganglion situated in pterygopalatine fossa. Pterygopalatine ganglion is important for innervating various glands in the face. The carotid sulcus present on the either side of body of sphenoid starts from foramen lacerum and reaches up to anterior clinoid process. The sulcus lodges the intracavernous part of internal carotid artery. The anterior part of petrous part of temporal bone forms the posterior aspect of the floor of middle cranial fossa. On the lateral part of petrous temporal bone, we can observe a distinct oval swelling, which is known as arcuate eminence. It is formed due to underlying superior or anterior semicircular canal of internal ear. This eminence is an important surgical landmark for procedures involving middle cranial fossa and temporal bone. Tegmen tympani, which is a thin plate of bone that separates the middle ear from the cranial cavity, can be found lateral to the arcuate eminence. The closeness of middle ear cavity and middle cranial fossa is the cause behind the spread of infection to cranial cavity in cases of otitis media. We must also note that fracture of middle cranial fossa may cause bleeding or discharge of cerebrospinal fluid known as CSF otorrhea. Medial and anterior to arcuate eminence in the petrous temporal bone is the presence of groove for greater petrosal nerve, which passes obliquely forward towards the foramen lacerum. The greater petrosal nerve is a branch of facial nerve which carries parasympathetic or secretomotor fibers that innervate lacrimal gland and mucous membrane of nasal cavity and palate. Therefore, damage to greater petrosal nerve can lead to gerophthalmia, that is dry eyes, and altered taste sensation. Parallel and anterolateral to the groove for greater petrosal nerve, we can also identify a groove for lesser petrosal nerve which runs forward towards the foramen oval. Lesser petrosal nerve is a branch of glossopharyngeal nerve and it carries parasympathetic or secretomotor fibers that innervate the parotid gland. Lateral to the foramen lacerum on the anterior surface of the apex of the petrous temporal bone, a shallow depression known as trigeminal impression is present that houses the trigeminal ganglion. The upper margin of petrous temporal bone on the anterior aspect has a groove for sensory root of trigeminal nerve. Lateral to this margin, the upper border of petrous temporal bone has a groove for superior petrosal sinus, which also acts as a site of attachment of dural fold called tentorium cerebelli. So this was the description of middle cranial fossa. Thank you for watching.